this session with Dr. James Litch and Courtney Barsh-Garvey, who are come to us from GAPPS, which is the Global Alliance for Prevention of Prematurity and Stillbirth. So Dr. Litch is the Executive Director and Chief Research Officer for GAPPS and the Principal Investigator for the Pregnancy and Childbirth Biorepository within GAPPS. He's worked in global health for over 25 years. This has included being a medical officer, an NGO program director, an advisor to the Ministry of Health, so a whole sort of range of different roles. At GAPPS, Dr. Litch led the perinatal interventions program and served as principal investigator for implementation science activities in Africa and Asia. And he'll be joined by Courtney Baruch-Garvey, who's a program manager for research initiatives at GAPPS. She's worked in the field of maternal and child health for over a decade. She leads a complex multi-country research initiative aimed at establishing international research cohorts in pregnant women to elucidate the causes of preterm birth and to develop appropriate novel strategies for prevention. She also manages access to the biobank through the GAPPS Bioservices. So we're looking forward to hearing from each of them. And who would like to start us out?
Hi, Sarah. I did be myself. Courtney's actually engaged with a 40th birthday party surprise for her husband. So she couldn't make it today.
Sounds good. Well, we're happy to hear from you, Jim.
Okay, great. Well, thanks. And I'll be providing a 5-minute overview of the GAPPS Biorepository. You know, we do focus on pregnancy outcomes, specifically preterm birth and stillbirth, because we see this as among the greatest challenges in pregnancy outcomes facing the world today. Preterm is, as you know, defined as birth before 37 weeks, and stillbirth is a fetal death after 20 weeks of pregnancy. What's interesting is it's somewhat of an epidemiological artifact to separate those two, and we like to think of it as together, stillbirth and preterm birth, which is perinatal death, constitute 80% of under 5 mortality. It's not really thought of much that way. And when you think in other ways, then other conditions like pneumonia and infection become predominant. Next slide, please. So GAPPS is a nonprofit organization. We're based outside of Seattle. We were formed in 2007. Our mission is to improve birth outcomes, and we do work worldwide as well as domestically, of course. And we catalyze and accelerate research interventions to prevent preterm birth and stillbirth, working truly collaboratively as an alliance. Next slide, please. Our team provides a vehicle with an ambitious goal to bridge basic, transitional, and implementation science in maternal and newborn health. And through that work, as challenging it is, at each step, each of those stages along the research gradient, we've come to deeply appreciate that there's a need for research with and about pregnant people, but also using longitudinal data, and that can be a real challenge, as you know. Next slide. So the rationale for our repository is to develop pregnancy research cohorts that are limited and, the challenges faced are that the cohorts in general that are available are limited and fragmented. They're uncatalogued and inadequately characterized biospecimen when and if they're collected. And they're in closet freezers from researchers who have collections driven by individual hypotheses. This, in fact, is an extremely costly in terms of research and time for these individual researchers to develop any large longitudinal cohort necessary to investigate more advanced research aims. So in 2009, with support from Seattle Children's and the Gates Foundation, the GAPPS longitudinal, next slide. Go back one. Yeah. Oh, no, that's it. No, that's correct. That's correct. I'm sorry. It's hard with the not controlling my slides. Thank you so much, Sarah. Since we were operating since 2009 with support from Seattle Children's and the Gates Foundation for our longitudinal pregnancy biorepository, And we currently use a replacement cost mechanism for biospecimen data use. The repository is widely accessible biobank of standardized, high quality specimens linked to very robust data from diverse populations of women and babies. And I'll talk a little bit more about their geography and others. Next slide. Our objectives for the repository are to implement prospective standardized investigations with consented women where these data are structured, harmonized, and consistent. We enroll with full consent early in pregnancy and follow throughout. And this is was a bit of a challenge in the beginning, but our IRBs have embraced this. And so we do collect agnostically without a particular stated single protocol or research question. We use early ultrasound dating of gestational age for all participants. And that's an easy statement in the United States, but in our international sites, that is a real game changer. And we've been very successful in getting very good gestational age data, which is a critical variable for all the work around preterm birth and stillbirth. We have standardized agnostic collections, like I mentioned before, and we are building and supporting repositories that are owned locally in international settings for better representation. Next slide. This is a snapshot of the biospecimen types and data we currently collected. We enroll in the first trimester, and we have 4 time points through pregnancy and postpartum, and there's a capability to conduct long-term follow-up as well. Next slide. These are our sites. The sites in red are our domestic collection sites, and then we have international sites. Currently, Zambia and Bangladesh are collecting, and India and Ethiopia are underway pending funding. Our enrollment by the sites where we have very active data are listed here in the slides. In the United States, we have recruited and followed over 2,800 pregnancies with extensive demographic and medical data, including complete medical record abstraction. This is about 1,700 data points for each pregnancy and 136,000 bank specimens. Over 30,000 of these specimen data dyads have been distributed to researchers so far to date. Next slide. Oh, I'm sorry. One more slide. I'm on sync with you. Yeah. So because of the short presentation, I'm just about done. I just want to say that this has improved efficiencies and reduced costs for many types of research. And this includes everything from chronic disease insights and lots of works around genomics and omics, but new therapies and prevention solutions as well. So really the whole gamut. Cross-cutting all of these is our work on deep phenotyping of preterm birth, which is, I would love to speak more about sometime. Next slide. And this all comes down to meaningful results. And in the past 7 years since specimen and data has been available, we started collecting about 10 years ago. Our repository has published over 75 peer-reviewed publications. Some have very high impact. These are a couple from the last year or so. Nature, mostly omics work, looking at biomarkers and new predictive diagnostics. But what's impressive, I think, most is for the point of this kind of agnostic collection is the time from query to the repository to publication has been very rapid. And these 3 examples were just 10, 24, and 30 months from dataset query to peer review publication. I mean, that's unheard of previously in any work I've been involved in. We are also trying to go beyond repository and data banking and move towards a knowledge base, working with IPQ analytics. And we'd like to integrate the current silos of development and enable analysis of gestational factors on the complex interactions of the mother, fetus, and placenta. And we think this will give lots of new insight and opportunity to investigate the impact on children and maternal outcomes by having even a somewhat new way or new perspective to approach these problems. So we collaborate with more than 35 public and private research partners now, and we continue to expand. And we hope that, next slide. And we hope that we can discuss with you some of our further capabilities in our repository and in our efforts to expand more to more underrepresented communities, particularly in Asia and Africa. Thank you.
That's awesome. Thank you so much. It's really fascinating work. And if I could open up with just one question for you, which is, I agree that your time from database query to publication is incredibly tight. Of course, some of that is because you had maybe exemplary researchers who were able to, do the analysis in no time, but there are so many repositories where it takes longer than that just to get permission to get started. So do you have any keys for us as we set up ways to access, through our data coordination center and whatnot? What has enabled you to have this quick turnaround?
Yeah, I made a quick mention of it on a bullet there, I think, but I think critical, and it's hard to go back and change, is the consenting process. The IRB you work with and the language you use is absolutely critical. And because so much of we all come from pretty much trial backgrounds where we're trying to protect that trial, focus on that trial, and get good power for our measure of effect. We write very narrow protocols, and that just seems like the language we know. We pushed ourselves, and we're surprised that IRBs accepted that we would do an agnostic collection, not defined by any given research question. Our research question was, if anything, could we do this? And it's really worked out. I mean, we have a utilization committee that was part of the IRB that determines what has scientific merit and capabilities that should have access. And that packet is put back as an addendum to our IRBs very rapidly. With a matter of a week or two, we have approval for any new protocol. So we can go from query to actual shipping and data assays within 2 months easily. I mean, it has taken longer, depending on when people are ready, but yeah.
Absolutely. Yeah, there's a question in the chat from Dr. Lewis, which is, can you describe how maternal medication exposure during pregnancy is collected in the biorepository data? For example, do you have granular data such as dose, and our data collected on perinatal and NICU outcomes?
I'm sorry, I missed the first part. There was a break. Can you repeat the question?
How basically what data do you have on medication exposures and how granular it is it? And then how about outcomes in the baby?
Yeah, we have well, I'll start backwards with outcome. We do, both are supported, our medication data and outcome data, by abstraction of the medical record. And that's quite robust. And we do both occupy data fields and capture language. So we can do other forms of analyses if we miss variables. And in fact, when we structure our data, we're always learning over the years that, oh, I wish we had this variable, and it's clunky, but we are able to go back, of course, and get that. So the second thing is about outcomes. I want to say is we do collect ICD-10 code, 9 codes, and discharge diagnosis that we can put as a variable into our data set. But we actually look at the primary clinical record, so we can do our own classification of the clinical outcomes based on the evidence in the chart. And that's actually really, really important, because there's a lack of fidelity among many clinicians on their busy day in research, and what ends up in a medical record intended for billing purposes may be actually really different than clinically what's exactly going on, particularly with the detail that's needed by research. The medication exposure is all simply from extraction of medical records, including lab and pharmaceutical nursing records.
And then what's maybe a brief question, were cord blood samples collected?
Yeah, they've not in all cases, but we attempted in essentially all.
Okay, and then we'll have one last question here, which is, what strategy do you use to expedite international IRB approval? Use central IRBs or international facilities in central IRBs?
Yeah, no, great question. It ties with that other one. IRBs and consenting is so important. We use all local IRBs for that, of course, and the ownership of data is by the investigators that we collaborate on site. So our GAPPS sites internationally are in fact independent of us. We're very close, but they own the data, they keep the data, and biospecimens are able to be shipped internationally. And this is difficult by country. So for us, strategically, we were located in countries that would allow international shipping of biospecimen. That's not always the case. And the argument being that countries would like to see investment from the North to improve the capabilities to do those technological advanced assays in the host country. So, and we've facilitated that as well. So I hope that answers the question.
Yeah, thank you so much. Really interesting. So our next